three guests who I'll introduce here in a moment. But at the conclusion of that, we would love to take questions from the press on our topic for today, which is the opiate crisis in the state of Ohio and in the nation. So please, as we are going through the remarks at the beginning of the presentation, if you have questions, feel free to either put that in the chat that you have a question, or feel free to raise your hand through the Zoom function. So we'll go ahead and introduce my colleagues that are here with me today. First is Dr. Trent Hall, who is an addiction medicine psychiatrist here at the Ohio State University Wexner Medical Center. Next is Carson Felkel, who is the System Director for Behavioral Health at Bon Secours Mercy Health. And last is Dr. Robert Zukas, who's a family medicine physician in Lima, who is very involved in the opiate treatment space and helping manage the opiate crisis for his system through Bon Secours Mercy Health as well. I don't think it's a secret to any of the media on this call of really what the opiate crisis has been like over the last few years. We've seen increases in overdose deaths to the point where overdose deaths in Ohio are the third leading cause of lost years of life for Ohioans. We've seen nationally pretty significant numbers of opiate overdoses in the past few years. And certainly the COVID-19 pandemic has added a new wrinkle to that, as people have really suffered from behavioral health and mental illness in a different way, often self-medicating or becoming addicted, or not really presenting for addiction treatment, maybe in a way that they did before. So as with many things, COVID-19 has really thrown a wrinkle into some of the systems that we at Ohio State, that other hospitals around the state have had to try and keep the pandemic under control. The reason why our colleagues are here for Bon Secours Mercy Health today is Ohio State partnered with Bon Secours Mercy Health back in 2018 to form the Healthy State Alliance. It's a cooperative entity between one of the largest academic medical centers in the country and one of the largest Catholic health systems in the country to really take best practices, whether it's in clinical care, in research, or in education, across a larger portion, not only of the state of Ohio, but with the expansion or the merger of Bon Secours and Mercy Health, even into other states in the United States. So it's been a terrific partnership. We've had a variety of focus areas, including cancer, including transplant, and in some other clinical areas. But one of our main focuses since the beginning of the Healthy State Alliance has been on the opiate crisis and a variety of partnerships that we've been able to put in place. For example, this weekend, we will be hosting a symposium for healthcare providers, not just from across Ohio, but from across other areas of Bon Secours Mercy Health in the U.S., with over 900 people registered to come and learn more about opiate prevention in terms of addiction, to learn about new treatment methods, and really to try and help to be sure that we're spreading the best practices in these areas across all of our system and even to other systems. So I'd like to start out a little bit with Dr. Zukas. A couple of questions. Can you talk about how this looks in the Lima area? What does the opiate crisis look like there, and what is St. Rita's specifically, or the Bon Secours Mercy Health System with OSU? What are we working on in your neighborhood?
Sure, absolutely. So, one of the things that we've seen is that the COVID-19 pandemic has really affected the care of patients, and particularly this group of patients, people with opioid use disorders and other substance use disorders, but particularly with opioid use disorders, we see a lot of our patients really struggling to access care. While the pandemic has really pushed forward telehealth, not all of our patients have the ability to log on to telehealth. They either don't have a computer or a phone to be able to access that. The stress of isolation, mental health issues often run hand in hand with substance use disorders. And so oftentimes we see that that is really affecting the increase and the spike in deaths from overdose. Some of our patients, and in talking with some of my colleagues from across the state and other projects, we've discussed the fact that a lot of times our patients will be in a sense triggered by the things that they see on television, with the vaccination, with the needles and the different, what to them is drug paraphernalia. To us is vaccination, to them is drug paraphernalia. And so some of them have mentioned that that's been a trigger for them. A large part of it, I think, has been some of our patients have dealt with a lot of family and financial struggles during the pandemic as well, and that of course affects the challenges and increase in use. Um, Not to mention the fact that this is an underserved population to begin with, and so they really struggle a lot of times. Populations that are marginalized to begin with during times of crisis are even more affected, and so we see that being a large part of it right now. Some of the things that the Healthy State Alliance has really attempted to do and has done very well. We see that we have about 170 providers that are waivered to provide buprenorphine for patients. So one of the medications that can be used for opioid use disorder is buprenorphine. And we have about 170 providers that are waivered now. And a lot of those people are people just like me, family medicine physicians that are taking care of a population of patients that we're able to provide that service to patients, our own people, able to give them something that can help them to avoid going back to different drugs of abuse. The Alliance has also created at St. Vincent Medical Center in Toledo, Ohio. They've also created a perinatal medication for opioid use disorder clinic, and that's been also very helpful. And we've seen that the people enrolled, or there's a program called Medications for Opioid Use Disorder, or MOUD. The participation has been steadily increasing and is now to more than 200,000 participants and patients across the Healthy State Alliance.
That's great. I think the perinatal program was really a passion early on when we focused on the opiate space. At Ohio State, we've had the STEP program, which is our version of the program for pregnant moms who are also addicted, so they can get their OB care at the same place they get their substance abuse treatment, in group therapy appointments. It's also been, I think, been a great example of how education features into this, because that's an area where Bon Secours Mercy Health has a residency program in OBGYN, so that we're educating the next generation of OB providers about how to set these up wherever they go in practice. But I know that was a real a labor of love by the folks in Toledo to get that off the ground, and to do it also with the backdrop of the pandemic has been outstanding. So
absolutely right. And as we'll hear a little bit later with the stigma, that helps to take away the stigma from the very beginning of the training program. The physicians are often educated from the ground up if they understand that this is something that we provide patients and that it's a necessary part of their care. The stigma is lessened.
I think the point you bring up about primary care physicians, family physicians being involved in this space, it reminds me a little bit of back when I was in training in the 90s. There was a time when primary care docs did not write antidepressants for patients. Everyone had to see a psychiatrist to get started on what are now relatively mainline medications and treatments that primary care docs do to, you don't need a psychiatrist to start someone on a low dose SSRI for, kind of routine depression that needs treatment, or sending them to a cognitive behavioral therapist. I feel like addiction treatment is kind of going that same direction. Does that make sense to you?
Absolutely. And I think that it's something that primary care really does what it has to do to help care for patient populations. And we love and really appreciate the specialists in the field, and we appreciate their guidance. We're fortunate that the ASAM, or one of the training groups that puts out the buprenorphine waiver training program, we're fortunate that they've handed down this extremely exceptional training program for us to be able to understand how to treat, how to provide in safe and effective ways.
Yeah, ER physicians, hospital medicine physicians, primary care physicians. It's a different team focusing on this issue than when it was just the addiction psychiatrists and counselors.
Absolutely, and it's great that we're a team. We are able to reach more people and help more people that way.
That's great. Switch gears a little bit to Carson Felkel. I know one of the professional passions that you have is really combating human trafficking. Can you talk a little bit about how the opioid crisis has impacted human trafficking?
Yeah, sure. Good morning, everyone. Thanks, Dr. Thomas. It's been a pleasure being a psychiatrist on the Bon Secours Mercy Health side, working with Ohio State. You all have certainly been really great at sharing best practices and helping us to learn together. I am a child, adolescent, adult psychiatrist, and am fortunate enough to take care of human trafficking survivors in a 2-year residential program. And this has been just an extraordinarily tough past 2 years. A lot of chaos that has triggered a lot of trauma in these individuals that we take care of. We know that trafficking is a dynamic crime, and traffickers are very smart and seek to exploit the chaos that we're living in. The opioid epidemic, we had been making progress over the past few years, but the numbers of opioid deaths have just skyrocketed for multiple reasons. One, just being the amount of fentanyl that's on the streets and synthetically is put into these opioid pills. But opioid use disorder goes hand in hand with human trafficking in multiple ways. It is a complicated scenario. In one way, sometimes through forced fraud and coercion, these men and women who are ensnared into trafficking do have an addiction issue. And then on the other hand, sometimes because opioids unfortunately are so strong at numbing the physical, emotional, psychological pain, these survivors will turn to them to survive. So it is a complicated process. We know that this is such an important issue that we can be shining a light on. So I appreciate the Healthy State Alliance allowing us to talk about human trafficking at the symposium on Saturday. We're actually going to highlight a survivor who is going to tell her story and talk about her struggle with heroin, how she had endocarditis and presented to the hospital system multiple times over her life. And it wasn't until much later was it recognized that she was actually being sex trafficked. So we can all in healthcare strive to do a better job of listening to patients to figure out what is that reason why they keep coming into the emergency department. It's so great that we are setting up perinatal opioid use disorder clinics because that is the setting that these trafficked women present most to with pregnancies or to our emergency departments. And then one last comment, Dr. Thomas. I think everyone is probably aware of the largest human sex trafficking sting that just went down in Ohio and Columbus. And so that just speaks towards the need for us to continue focusing on this very important issue.
Yeah, thank you, Carson. The teaching of nurses and doctors and social workers to really look for those signs of human trafficking, very reminiscent to me of training many of us went through around domestic violence in the same way, looking for those subtle signs, because most likely people don't come in with that as their main complaint. They're there for other things. You want to talk a little bit about what sometimes those visits look like, where those subtle signs are?
Yeah, it's really important to pick up on nonverbal cues. One of the historical red flags was the patient had a cell phone on in the emergency department room. We all carry cell phones these days, so we really have to be thinking outside the box. The main point is that in healthcare, we can't necessarily rescue these men and women, because through forced fraud and coercion, largely emphasizing coercion, a lot of these individuals do not think that they are being trafficked. They believe that their pimp is actually their boyfriend and loves them. And they're not going to just divulge that they're being trafficked because they don't believe they are. And so what we have to do in healthcare is create a safe place where they know that they are cared for, and we will be there when they're able to have a little insight into the fact that they want to leave that life. There are things we can do that are very practical, like if a patient comes in and they're using $400 of opioids or heroin a night, in a very trauma-informed way, asking them where they get the money to pay for those drugs can open the door into a conversation around the fact that they're actually selling their body.
Thanks for sharing that, Carson, and your commitment to that, and Bon Secours' commitment to that space and the program you work in is really outstanding. Trent, switching gears again, thinking about, and actually Carson mentioned this in one of his remarks, thinking about stigma, thinking about ways that we want to not trigger patients when they're in our environment related to the words we use. Can you talk a little bit about terminology and how we've been working through the Healthy State Alliance at educating providers, nurses, and et cetera, in the healthcare field around stigmatizing words and the impact that can have on patients?
Thank you, Dr. Thomas. Absolutely. So stigma is a really important topic in addiction. We know that stigmatizing phrases, have the potential to reinforce negative stereotypes about individuals with this chronic health condition. This is a problem because scientific studies have repeatedly shown us that stigma is a barrier to care for people with addiction. So we know, for example, that stigma can contribute to avoidance of care. It can lead to delays in accessing potentially life-saving treatment for this chronic, often deadly disease. And even for individuals who are able to access addiction healthcare, stigma is known to reduce their engagement and contribute to poorer outcomes. So as you mentioned, within the Healthy State Alliance, OSU is fighting addiction stigma in a variety of ways. So one of those ways is through our research. We just recently launched a study here at OSU. We're collecting data at multiple sites. So Dr. Zoukas mentioned, primary care, and we also talked about obstetrics and gynecology and psychiatry. So fortunately at OSU, we provide care in all of these contexts. So we have 6 different data collection sites where we're asking individuals with opioid use disorder to share with us their experiences of internalized stigma or self-stigma and how that impacts their social functioning and their self-esteem and depression, and also their expectations of addiction treatment. So research is an important way that we're fighting stigma here. Additionally, we're doing public advocacy. So for example, this press conference, but also a variety of lectures and seminars that we're doing internally within our departments, but also at other institutions. And then finally, finding new ways to innovate and provide direct healthcare provider training to change also the way we're communicating about our patients, both in person and also electronically through the health record. So we're fighting addiction and stigma in a variety of ways, but despite that, addiction stigma remains common among healthcare providers, as well as the general public in Ohio and across the nation. And the truth is that, all of us on this call have a role to play in reducing addiction stigma.
Certainly makes it more likely that patients are going to get the treatment they need, both in terms of them coming forward, but also that recognition of providers of when they're screening someone and when they're, even working with other colleagues that aren't in the addiction space, to have folks really approach the patient in a person first perspective. You want to talk a little about what that term means, person first communication and terminology?
Absolutely. So, we've talked about how addiction stigma is harmful to patients, right? Reducing access, adherence, outcomes of care. But the question is, what do we do about addiction stigma? How do we affect change? And PersonFirst Language is a very powerful tool at helping us all fight addiction stigma. So PersonFirst Language is exactly what it sounds like. It is the non-stigmatizing, clinically accurate alternative to stigmatizing language, and we're really putting the person first. Putting the person first and the disease last. So an example might be, a man with opioid use disorder, a woman with opioid use disorder. We often talk about person first language in the context of addiction care, but it is actually the preferred way of, talking about anyone with a chronic health condition or disability. So person with diabetes, person with tetraplegia, person with opioid use disorder, and trying to normalize person first language as a part of our clinical communication about really all of our patients to whom it applies is essential.
It reduces that I think human tendency to stereotype based on when you hear 50-year-old diabetic or 50-year-old drug addict as opposed to a man with drug addiction. It's great.
Absolutely. So I mentioned it's kind of the clinically accurate alternative to stigmatizing language. And one of the reasons why it's so powerful is that research has shown that when healthcare providers are exposed to person-first language, they are more likely to come up with an evidence-based treatment plan for that patient. They're more likely to engage them in appropriate care. However, the same provider, if they are instead hear the patient described using non-person first or stigmatizing language, they're much more likely to think of the patient's health condition as a moral failing or a personal problem. And it sort of shuts down our scientific thinking about that patient. It shuts down our humanism. It prevents us from thinking about all of the training that we have had to help this person. And that's one of the most important reasons why it's essential that we use person first language with each other. But I encourage healthcare providers and the general public to just default to person first. We should be using person first language when we talk to each other, when we talk to our patients, when we talk to their families, when we're engaging with the press in briefings such as this, because all of these are opportunities to interrupt this devastating cycle between addiction, stigma, and poor outcomes for this potentially fatal disease.
Thank you so much, Trent. I'll remind our members of the media, if they have questions, please enter your name in the chat function or raise your hand. And I think my colleagues in media relations will be looking for those. A couple other questions. Carson, talk a little bit about how the COVID pandemic specifically has had an impact on human trafficking in terms of societal changes and other things that have potentially made that what was a bad situation actually worse.
Yeah, good data is still coming out, Dr. Thomas. So we don't really know exactly if human trafficking has increased or decreased, but what I am sure of is that it's because it's a dynamic crime, it has shifted. And what I mean by that is we know that through people's job loss, social isolation, this move to virtual, which has been in some ways a silver lining for some career paths, has also moved prostitution, escort, trafficking onto the internet more. As people being out on streets and going to dinner and all of that has decreased, the amount of vulnerability from internet has greatly increased. This is incredibly important because then you have an even higher tendency to exploit minors. And all of our kids who are now doing virtual school, there's more of an emphasis on how can we as parents talk to them earlier around safety of internet due to this devastating crime.
Thank you. Dr. Zoukas, as a primary care doc, I know we've definitely done prevention for years, whether it's wearing seatbelts or stopping smoking or getting someone to exercise a little bit more. Can you talk a little bit about what you talk to your patients about related to the risk of opiate addiction? Not that they have problems with addiction currently, but you're giving them a pain medicine for after a surgery or pain medicine after a broken something. How do you talk with them about reducing either their risk or their family's risk for addiction?
Sure. I think a lot of what we do here, especially being affiliated with the residency program, is helping residents to know what the appropriate indications, first of all, are for opiates. And they do have a place in acute pain care. They do have a place in chronic pain care. And what does that look like? And how do we appropriately identify a patient that for whom this is right and for whom this may ultimately be helpful as far as their quality of life? So number one is proper identification for the indication of opioids. I think the second thing, really when we speak with patients about these medications, as short as 20 years ago, we were told that these medications, or even 10 years ago, that these medications were not addictive, and that there were some of these medications that were not addictive. And we know now that that is not the case, that these medications are addictive, and some patients are highly addictive. And so we encourage patients to be very careful. Oftentimes we'll address patients initially with the initial prescription, especially if it's an acute problem, say a broken bone or something where we need to give them some pain control with opiates, we'll say, hey, this is a 5-day prescription, or this is a 3-day prescription. The pain should, in large part, subside after this, and so we help them understand kind of the natural course of the pain, and then mention that this is a highly addictive substance and to some people this becomes a huge problem, and so we need to ward that off to begin with. Oftentimes, when patients know that, or when they hear that to begin with, they're a lot more careful with the medication. They start to self-identify things that might lead them to believe that they have a problem with the medication, maybe timing out their doses and realizing that they're not just using it for pain anymore, that they're using it for other things. I think the other thing is to make sure that they're safe with the medication, to make sure that they lock it up in a cabinet or closet, to make sure that it's not accessible to anybody else that might seek to misuse that medication. In part, the states have helped us with this and to a large degree, because they've limited how much we can prescribe at the first prescription for acute opioid prescriptions. We're now limited to a 7-day supply, which is, in my mind, is an awesome thing. It helps to quantify that and helps us to not go overboard and have extra pills or extra medications sitting out in the community in any given place where they can be placed in the wrong hands or diverted into the wrong hands where they become more of an issue.
Great. Thank you for sharing that. So I want to thank our guests for being here today, Dr. Robert Zukis and Dr. Carson Felkel from Bon Secours Mercy Health, and Dr. Trent Hall here from the Ohio State University Wexner Medical Center. I did put in the chat the web address for the Healthy State Alliance, which is www.healthystatealliance.org. There you'll find information about the symposium for Saturday. As I mentioned, we have over 900 providers, physicians, nurses, pharmacists registered for the event, and look forward to another great educational conference on a really critical topic for all of us. So once again, thanks to members of the media for being here today, and we look forward to seeing you back at our next briefing. Take care. Thank you all.